You see, because you're doing integrated exam now, the results are going to be out for, the composite of all the subjects you did in the integrated one. So it's not a question of just the Poda group ready for your grades. The others have to be ready at the same time so that the results can be given to you in one single block. For those of you who did Poda alone, I think the same thing is going to apply. So it's Ms. Johnson in the Dean's office that is handling that. Brandy, you can speak to Dr. Fatu on behalf of the Pharmaceutical Sciences group to know what exactly is going on as far as your grades are concerned. But as far as I was concerned, the grades have been ready a day after your exam. I've given the grades out. So if there's any kind of delay, it's just because they are, the group has to have a composite grade for the whole course. They are working that out. So that's fine. But if I should be able to get some information by the end of the day today. All right, today.
Dr.
Yes, ma'am.
Ms. Johnson handles the grades.
She enters the grades.
And she sends it to the professor.
There's still a link that we're trying to establish because it's only professors that can post on the blackboard. But we got to get what we need to post on the blackboard on the basis of questions and grades and all that.
That's what I mean, like Ms. Johnson, she generates whatever
she generates what we need to put on the blackboard. That's what I said to her. Okay. All right, please. All right. Okay, today we'll be moving on to another aspect of the vascular system. I will be dealing with them.
Record.
Oh, record. Okay. All right. Thank you. I was recording before. Yeah.
No, not yet. No.
All right. So we move on to another aspect of our cardiovascular system. And in this case, we'll be dealing with arrhythmia. Arrhythmia, when you did physiology, must be one of the toughest aspects of physiology to understand because of the different ionic movements and all that. And even when you go to read your classical textbook on arrhythmia, it's so confusing. So what I've done is I've condensed as much as possible the very important information that you need. That's why the 3 hours were given for the lecture and may finish in less than 2 hours. Okay? So help me God. So I'll give you the most essential things, which means if anyone confronts you and asks you a question about anti-arrhythmic agents, you should be able to say some things, even on a general note, that shows you have some understanding. So for the case presentation today, it talked about Dr. J, who was lecturing on the treatment of cardiomyopathies, and he felt his heart beating irregularly. That's one of the things you notice about arrhythmia, irregular heartbeat. And he becomes nauseated. He was able to finish his lecture, but he continues to feel significantly short of breath. One of the reasons that somebody having arrhythmia will feel short of breath is because the heart is not having enough time to do what it has to do in terms of the sequence of things. And don't forget, the heart rhythm, or the heart works in a way as if in a relay system. In a relay system, somebody picks up from the starting point, hands over the baton to the next person. The next person hands over to the next person hands over to the next person. That's what we call a normal rhythm. But when the heart is out of rhythm, that's why you find, let's say, the first person, after the whistle goes, on your mark, set, go, is still there. There and then, he's not going to get to the next person on time. So what's the first person, in my analogy, in terms of the heart? What is this first person that sets off the race? And what's the organ, or what's the structure? The SA node. SA node is the one that you should see as the first person that sets off the race. The SA node generates the impulse, transmits it to the AV node. That's like handing over the baton to the AV node. Then the AV node takes it to the ventricles, to the Purkinje fibers and stuff, and from there it returns. The rhythm is complete. Anything that disturbs that flow, of course, will make the heart not to function properly. Therefore, there's not going to be enough of oxygen or enough of nutrient supply to the rest of the body based on the function of the heart. That's why someone that has arrhythmia will be short of breath. Okay? Then go to the second paragraph where it talks about physical examination, what it reveals. The physical examination reveals that the individual has what? Has let me make sure I'm using the right. Huh? Still have to use your laptop. Okay. Okay, alright. Okay, physical examination shows an irregular heartbeat, of course. And then when you go on and things that happen, then there will be atrial fibrillation. What the guy has been diagnosed to have is atrial fibrillation. That is one of the forms of arrhythmia. And I'll mention some of them, other ones later on. For which diltiazem was given. And you know, diltiazem is a non-DHP, CCB, specific for the heart. Okay, good. And why that one, of course, the heart rate decreases to 80 to 100, which is now in the normal range. But its reading remains irregular, which means some medications that you use for arrhythmia may be useful in some form of reducing the heart rate if it's beating too fast, but it may not completely normalize the rhythm. Okay. Then the next paragraph talks about another thing, mentions a particular drug, ibutylite, which I will come to later on. Then the last paragraph is Dr. J. Fitzmine has forced multi-developed recurrent palpitations, and for which had to start him on amiodarone. Some of the medications that we'll talk about today will be amiodarone, ibutylite, and some of the other group, and the calcium channel blockers. Then there are questions that follow, which I don't want to bore you with. Now, so today, what I tend to do is we will review the 5 phases of action potential, because you need to understand that in order to know how some of these drugs work. I'll list the types of arrhythmia, and I'll mention to you mechanisms involved. And very importantly, I will take some time on letting you know the predictable effects of antiarrhythmic agents. And this is important because even if you don't know some specific information, you must be able to know that an antiarrhythmic agent, what can I predict it will do, especially when it comes to action potential. So when you are able to know this, even when you find yourself in a group of clinicians or others and they say, oh, well, what does this antiarrhythmic do? You can say, well, I think it does this, it does this, it does that. At least it will show you have some good knowledge. Okay, so I will talk about the 4 classes of antiarrhythmic agents. I will give you examples and the mechanism of action. I will talk about the pharmacology of prototype drugs. Now let's start off with the normal electrophysiology of the heart. Now you know that the impulse starts from here, and that's the first person in the relay race, the SA node, transmits the impulse to the AV node. From the AV node, along the Purkinje fibers of bundle of E's, it supplies the ventricles. Here, the left and now the right ventricles, from which another impulse now generates. Now, with each of the structures, there is an action potential that is generated. And when we say an action potential is generated, because there's a stimulus. When the stimulus comes, and the stimulus passes a threshold, it generates an action potential. That's what we call threshold potential. That is the potential above which nothing can happen. But once the stimulus passes that threshold, then it generates an impulse. And I would like to demonstrate that in one of my friends. Daniel, come here. I don't want to. No, stay there, stay there. So you understand the issue of threshold potential and not. Okay. I'm exerting some pressure on you here. Do you feel anything rather than my touch? No. Okay. So when I do this, what do you say? Pinching, and what did you feel? Oh, yeah, you feel pain. All right. The other one is, can you stand up? And face the glass. Okay, now. That'll be your hand like that. Okay. So, I'm generating. Let me see. All right. All I'm doing is that some people have their sexual potential so low, you almost have to pinch them before they even put their others before you even put their hand. So, what I'm talking about is there is a stimulus. If it does not go above the threshold potential, there will not be an action potential. When there's an action potential, then there is action. Okay. And that's when an impulse cannot move from AB from the SA node to AB node. You understand me? Alright. So, and when the impulse arrives at each of the structures, it will generate its own action potential, its own action potential, its own action potential. What you refer to as the electrocardiogram or the EKG, therefore, is a summation of an electrical activity of what happens in each of those zones. For example, I will talk about the P wave when I thought. The P wave represents the action potential in the atria. And once the atria is finished, it goes to the QRS, which is the ventricles. From the ventricles, then it goes through the T wave, which prepares the heart for the next phase. You understand it now? So this will constitute one heartbeat. So when the heart beats like this, it's a combination of 1, 2, 3, 4 things. And then when you have arrhythmia, it may be that the heart goes from 1, 2, 3, and then it goes to. Okay, that's arrhythmia. It loses the rhythm, and it may be due to a number of things. Okay, so let's go to the next one. And my next one, we just review what are the ionic changes that happen during the different phases of action potential. There are 5 phases of action potential. 5 of them. There's the phase 0, there's the 1, there's the 2, there's the 3, there's the 4. And I know I've taught you this before, but because this is important today, I will mention again. This is your threshold potential. And you know the resting membrane potential is at the negative value, right? Okay? So here is the stimulus. The stimulus is there, but it does not reach the threshold potential, so it does not generate action potential. Here, it generates action potential because it is strong enough to cross the threshold potential. So the first phase of the action potential is what we call phase 0. And during phase 0, the ion that moves into the cell is sodium ions. Sodium ions moves into the cell. And because it moves in fast into the cell, you call it fast inward channel. And it's fast because it's like from here, it's choop, choop, choop. So it's not slowly rising, it's very fast. That's why you call it fast inward channel. Then you get a phase 1 here. In phase 1, what you get is there's a repolarization. Of course, here is depolarization. It's depolarization that generates action potential. So when you find a little reversal here, that means there's a repolarization. And you call it early repolarization, because there's another stage of repolarization that is late. So when you get to that stage of repolarization, what it means is that there is a decline in potassium channel, and there is some inactivation of this channel, because if it's not inactivated, you will not find it reducing in potential. The next one is phase 2. During phase 2, calcium moves into the cell, and sodium also moves into the cell. You call this slow because you can see it's a slow, it's not this fast one that's there. Just fast like that. And when you get to phase 3, this is the repolarization phase now. And this is the slow outward current, and this is the late phase of repolarization. This is the early phase of repolarization. What happens during repolarization is that potassium moves out of the cell. Potassium moves out of the cell during repolarization. And once the repolarization stage is completed, it sets the stage for the phase 4, which means the heart muscle is now rested and is ready for the next action stimulus, ready for the next action potential. See, the heart cannot continue to be in depolarization. When there's depolarization, there should be repolarization. Depolarization, there should be repolarization. Because the repolarization allows the heart to prepare itself for the next stimulus. So what then happens during arrhythmia is that you may just have too much of depolarization. So you need to slow that down. And when we talk about arrhythmia, I want you to have at the back of your mind that though there can be a slowing of the heart rate, there can also be an increase in heart rate. Typically, most of the time in arrhythmia, when we talk about it, we talk about the increase in heart rate, when the heart loses its rhythm. So there's tachyarrhythmia, there's bradyarrhythmia, but most of the time we refer to tachyarrhythmia because that's the one we do not want. So next slide, that talks about what are the factors that can precipitate or even exacerbate arrhythmias. Ischemia. If there is insufficient oxygen and nutrient supply to the heart, that makes sense. And that's where sometimes you find a patient that has angina will eventually manifest arrhythmia because in angina, there's atherosclerotic plaque that's blocking the coronary artery. Supply to the part of the muscle being supplied by that vessel is compromised. Not enough oxygen, not enough nutrients. Hypoxia is a worse form of ischemia if it progresses for too long. If the pH of the heart is too low or too high, it can precipitate arrhythmia. If the myocardium is diseased, like you have myocardial infarction, you cannot find a successful transmission of action potential between one tissue and another. A good example, if you want to talk about the analogy I mentioned about a relay race, is this. Somebody carries step 1 or first leg, the other one carries second leg. The third leg was carrying it only to run into a big ditch. There and then, the impulse cannot go anywhere. That's an example of a diseased myocardium or myocardial infarction. You can do that. Drug toxicity. Digitalis, as good as they are as cardiotonic drugs, can cause arrhythmia. And funny enough is that some antiarrhythmic drugs too can actually cause arrhythmia. And I'll mention that in a short while. Overstretching of cardiac fibers can do the same thing because when you overstretch, the heart is making it difficult for the SA node to do its regular job in a normal fashion. And when there's excessive catecholamine exposure, catecholamines will increase the heart rate, will increase the contractility of the heart, that can cause arrhythmia. But I'm saying here, regardless of any of these factors, all arrhythmias, all of them, will result from disturbances in impulse formation. What do I mean that? If the impulse being formed in the SA node is inadequate, or there's a disturbance at the level of the SA node, you're going to have arrhythmia. So if the pacemaker activity, that's the SA node, is wacko, it's going to cause arrhythmia. impulse propagation. That means even SA node has done its normal job. It generates the action potential, but it's not able to reach the AV node. That means the impulse generation is adequate, but the propagation is inadequate. It comes to the same thing. The number one starts off, the first leg runs correctly, but then just when it's about to give to the second leg person, something happens, it stumbles. That's what we mean by impulse propagation. So you see there, disturbance in formation or propagation, or both of them, will cause arrhythmia. And this is just to let you know some types of arrhythmia. Not that you will ever have to read them, but when you talk about normal sinus rhythm, this is when you have a normal P wave, one QRS, and one T wave. That's a normal sinus rhythm. Anything that deviates from here is abnormal, and that would be arrhythmia. So when you have something like atrial fibrillation, you look very well, you will find two P waves before a QRS wave. It doesn't work that way. So that would be arrhythmia. Next one is if you have, what is this? So is that fibrillation or flutter? Can read it correctly from here. That's, it's fibrillation too. Okay, all right. So that is a form of arrhythmia too. Then this is when you talk about atria. What about the ventricles? The ventricles can go into fibrillation, and that's what we call a ventricular fibrillation. What do you find in a ventricular fibrillation? There will be no P wave at all. No P wave. And the same thing you have when you have ventricular tachycardia. These are all forms of arrhythmia. Now, the next page talks about the different types of arrhythmia, and I'm not going to ask you questions on this, just to let you know that when you have what you call atrial flutter, different from atrial fibrillation of ventricular fibrillation. Atrial flutter is when the atrial rate has gone as high as 280 to 300. And the firing rate is now 2 to 1. The normal firing rate is 1 atria, 1 ventricular. Once you have atrial flutter, you have 2 atria, 1 ventricular. That's what it means. And you have the other one, ventricular fibrillation, supraventricular tachycardia. When you refer to supraventricular, that means it's occurring above the ventricles. And you can have sinus tachycardia too. You can have paroxysmal supraventricular tachycardia. You can have, and there's a particular one I'll mention, torsade de pointes. Torsade de pointes is a form of ventricular fibrillation too, you know. And in this case, it has its characteristics, but it's a dangerous form of arrhythmia. Torsade de pointes. Now, when we talk about the pharmacology of antiarrhythmic agents, this is where I now want you to pay attention. This is one I don't want you to memorize. I just want you to understand it. So if you have, and I need your participation now, so I need everybody to participate, because this is the key point of the lecture. Have at the back of your mind that arrhythmia is something that just goes pa 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 pa. Okay. And you know the heart can beat automatically. It doesn't need any innervation. Okay? So what do you think will happen when you have an antiarrhythmic agent with respect to automaticity? Should an antiarrhythmic agent increase automaticity or reduce automaticity? Reduce. Everybody agrees? Okay. It should reduce automaticity. Because in that case, you're trying to keep the heart in. All right, good. What about the rate of the pacemaker? Should it go up or should it go down? It should go down. It should go down. It should go down. Thank you very much. What about the conduction or excitability of the heart? It should go down. And what about conduction velocity? It should go down. What about refractory period? And when we talk about refractory period, there's a refractory period for the atria. Because the atria should have a time to relax too. The ventricles must have time to do that. So that's one for the atria, we call it ARP, atrial refractory period. The one for the ventricles is ventricular refractory period. For the whole of the heart, we call it effective refractory period. So what do you think should happen to refractory period in a fast beating heart? Increase. Is that clear to all of you? Clear?
Yes.
This is good. What about the refractoriness of the nodes? Let's say the AV node or the ST node. Should they be refractory? Should it increase or should it decrease? Why would it increase?
From the SA node to the AV.
Speak up, I can hear you, so I can imagine.
It's supposed to reach the next node.
It's supposed to reach the next node. So? Without any disturbance. So that's why you will increase the refractoriness. So you can make sure it reaches the other one in good time. You give this a good relaxing time to reach the other one. And the way I always look at this, your class, I want to believe the whole class is with me in this one. In the past, there has been some confusion as to whether the refractoriness should increase or should decrease with an antiarrhythmic agent. And let me tell you the analogy I always use. You are married, right? And I know your wife loves shopping. She doesn't love shopping. Is she not a lady? You're married to a lady, right? You're positive. Okay. And with children, right? Okay. Now, you find your wife that likes to shop. Mine does. And I thought you said no. Now, because I'm confessing, now you say yes, mine does. You see how this man acts? Okay. Don't trust this man. Don't trust this. Okay. Now, so you have a lady who always likes to go to Neiman Marcus every moment.
Yes, sir.
Every moment. And you want to stop the lady from doing that. Do you want to increase the number of times she goes to Neiman Marcus, or you want to decrease? You want to decrease the number of times she goes, so you now have to increase the refractory period so that the time she goes, if she goes like every 6 hours, let's say every 6 days, you now want to increase it to every 15 days or every 21 days. That's how you increase the refractory period. You understand me now?
Yeah.
Okay, and the same goes for action potential duration. Because if the action potential is not completed, one is not completed, the other one will not take place.
Oh,
That's right. So the duration of the action potential in this graph would be okay. Action potential duration will be between here and here when the whole action potential is completed. That will be the duration, and that's what we call the APD. And there's an action potential duration for each of the structures, whether for the heart and for the atria and for the ventricles. And that's why you have the AAPD or VAPD. Now, what about repolarization? You know, repolarization is a situation where it's the opposite of depolarization. So do you want to increase the repolarization or you want to decrease the repolarization? Decrease the repolarization, decrease. I'm hearing decrease, I'm hearing increase, but I'm hearing increase too. That means I should pick one of them. Those of you saying decrease, I want to make sure you are saying decrease, not decrease. So, all right. Do you think repolarization should increase or should decrease?
Increase.
It should increase. It should increase. It should. Thank you, my lady. It should increase. Should increase. Okay, so that's your general picture of anti-arrhythmic agent. So once you get this, there are some of the facts that are removed. It's a lot of junk from your textbook. That's why I condensed this to here. If you're able to do this, you can fool your way. Not for it. You can't fool your way in my exam. You know that. You can't do that. But you can fool your way when you get out there and you say, and you're in the midst of doctors and other pharmacists. Like, oh, yeah, I know that. Okay, now, so let's just do this quiz, and it was part of what I sent to you as a lecture. So hopefully, if you didn't get it before, you should get it now. Which of these effects is not a predictable effect? Three? Everybody agrees? Three. Very good. Okay. Let's go to the next one. And so let's go to the major mechanisms of action and classes of antiarrhythmic agents. There are 4 classes of them. 4 classes, and they act on specific phases of the action potential. That's why I took some time to go over that electrophysiology. You have the class 1. All they do is they block phase 0. And that is the phase when sodium moves inside the cell. So they are sodium channel blockers. So their mechanism is sodium channel blockade. Of course, there are 3 subclasses, 1A, 1B, 1C, and I'll get to that in the next slide. Next class is the class 2, which are the beta blockers. They block sympathetic autonomic effects, and by so doing, they act on phase 4. Class 3 are those ones that prolong phase 3 repolarization. They prolong phase 3 repolarization. And class 4 are the calcium channel blockers. Now, this classification is not absolute. And it's not absolute because you have situations where some of these agents, though they are classified in one particular group, they do have actions that spill and share actions with the other grouping to which they are not listed. And I will give you an example of those ones. So this classification is not absolute, but once we say a class 1 agent is a class 1 agent, that's how it is classified. So if my question says, is X a class 1 agent? And the answer is yes. But if the question says, does this drug affect sodium channel? You need to know that it may have belonged to another class, but it can also block sodium channels. Watch out for the difference in the framing of the question. That's what I'm talking about. Then, anti-arrhythmic drugs generally can therefore modify the impulse generation or the impulse conduction, as I told you in terms of arrhythmia. And many of them are clinically useful in reducing morbidity in selected cases. However, many of them are known to have dangerous pro-arrhythmic effects. They're anti-arrhythmic, they're so strong and so potent to the point that they start acting as pro-arrhythmic agents too. And one class that's notable for that are the class 1C agents. Class 1C agents are particularly notorious for being very good, but then they can cause arrhythmia themselves. So if you look at this slide, that makes it easier for you to see where the different classes of agents are acting. Class 1, acting on phase 0. These are the ones that block sodium channels. Class 4 are the ones that block calcium channels. These are the CCBs. Class 3 are the ones that act on phase 3, and these are the ones that block potassium channels. And class 2 are the ones that block sympathetic nervous system activity. So let me give you this and tell me your answer. Which of these mechanisms is involved in the treatment of arrhythmia? Blockade of sodium channels?
Yeah.
Yes.
Opening of calcium channels?
No.
Opening of potassium channels?
No.
Block, right? Okay. Now, so let me just start off with this. And what I'll do is I'll just start off with this one because the class 1 agents happen to be one of the more difficult ones to understand because of the different actions that they have here. They are fast sodium channel blockers. They act on the zero, and it also prolong repolarization. Okay, so that's one of the things that makes the teaching of antiarrhythmic agents or the understanding difficult. You would think an agent that will prolong repolarization is acting on phase 3, right? But then these are phase 0 agents. They block sodium channels, but they are also able to prolong repolarization. And you will see why. So there are 3 of them, the 3 classes, class 1A, class 1B, and class 1C. God help you how you figure out how you know which one is class 1A or D. I think you had excuse me, my lady, you were showing me a good mnemonic last week.
Oh.
She has some excellent ones. I was almost going to copy them from you, but because I'm not writing the exam. So, but she has some really great ones the way she mapped that up. So you may have to do that for this one. So this is prokinamide, this is quinidine, this is disopyramide. What do these ones do? They have a moderate effect on sodium channel. Moderate because instead of allowing the phase 0 action to just go shoot, they reduce the rate of entry of sodium into the cell. And that's why their slope is shifted to the right. So when an impulse comes to a heart that is fast beating, and you disallow the action potential to take place immediately, but slow it down, that's why you call it moderate sodium channel blockade. Now, what does it now do? It prolongs repolarization. Prolonged repolarization. Don't be surprised. What do you think will happen to action potential duration from? Action potential duration?
It should be longer.
It will be prolonged. You can see it from the diagram. It will prolong the action potential duration. Okay? Now let's go to the class 1B. Typified by lidocaine, mexiletine, and phenytoin. This is very mild compared to this. And if anything, it even shortens repolarization a little bit. Any effect on action potential duration? No. No. Then you go to the class 1C. You can see how much this slows the rate of sodium entry. And these are the ones that are the most potent. And they are the same ones that are pro-arrhythmic in the process of doing so. Because they market sodium channel blockade, no change in repolarization, and no change in, if anything, they will reduce the action potential duration because of, no, not so much, they reduce the repolarization, but the action potential duration remains the same. This is typified by flecainide, enfinide, and the 2 other ones, morizine and propafenone. As far as this will be the last slide I will do. Okay, as far as the class 1 agents are concerned, there are 3 of them. Quinidine has an anticholinergic effect. Now, because you have done your parasympathetic, you have done your autonomic nervous system, once you hear cholinergic effect or anticholinergic effect, you can figure that out. But the thing is, the good thing, I'm not going to ask you a question on quinidine because it's no longer used. So, but we need to know it. So we'll limit you to two other ones. Procainamide. Procainamide is a ganglionic blocker. And if you remember what ganglionic blockers do, this is exactly what you should apply to procainamide. It causes vasodilation because by the time you block the ganglia, the transmission of impulses, the transmission of neurotransmitters is affected. It causes vasodilation. But importantly is after a prolonged use, it will produce a lupus-like syndrome. And interestingly too, when it undergoes acetylation, the acetylation of procainamide will yield what we call N-acetyl procainamide, NAPA. This NAPA now has a class 3 effect. So the procainamide is a class 1A agent, but this metabolite has a class 3 effect, which means it can cause repolarization. It can prolong repolarization. So if you see the prolongation of repolarization in the previous slide, that's the class 3 effect. That's all I will expect you to know about procainamide, apart from the other general, the predictable effects. Then disopyramide is similar to quinidine, but it has fewer GIT side effects, but it has more anticholinergic effect than quinidine. As for class 1B, lidocaine, mexiletine, phenytoin, you know lidocaine is a local anesthetic, you know phenytoin is an anticonvulsant agent. Mexiletine might be the only one you're not too familiar with. But then, as for the prototype, lidocaine is the prototype agent. It's very safe for use, and it has local anesthetic effect. Mexiletine just happens to be an analog of lidocaine, and phenytoin is an anti-epileptic agent. The class 1C are the most potent sodium channel blockers. They are pro-arrhythmic. And with this, let me end the class for today. And I'll continue tomorrow. Online. I'll do online tomorrow for you. Is that okay?
Yes.
All right. I'll do online for you. Any questions?
I have a question.
Yes, ma'am.
I noticed when repolarization didn't have any.
Hold it. Stephanie and Katia. Yes. Wait until you become professors and you talk at the same time as I do. Yes, that's all right.
I noticed when there wasn't a change in repolarization, you mentioned there wasn't a change in action potential. So does those two go hand in hand?
No, not necessarily.
Oh.
Not necessarily. Not necessarily.
Just one thing?
Okay, so I'm ending the recording, and then I will see you tomorrow morning.